We want to teach parents that this kid needs some special kind of care, the same way if your child had diabetes and needed a special kind of recipes for his food. It's not that you're a bad parent, you just don't know how to treat this particular parenting of this child.
Welcome back to another episode of That's an Issue. For those asking, yes, Dr. Tara and Yoni are married. It was only one person asking, and we've addressed it before, but that's why we like having them as the host. You have someone who's a doctor, a psychologist, and used to the field, and Yoni, who's a lawyer, who's not used to the field at all. And putting them together, and they're married, so yeah, it's just a lot of fun. So this week, they sat down with Dr. Glenn Hirsch to talk about kids, ADHD, focus, how to best raise our children. This is a fantastic episode if you have children and are always thinking, how could I better take care of them? How could I better help them focus? And even if you're an adult also, I personally, I was like, oh, this is actually very helpful for me, myself. Here is their conversation with Dr. Glenn Hirsch.
Mental health, relationships, those are loaded topics and something that affects every part of our lives. But we aren't having enough open conversations about it.
And that's an issue. Welcome back. We are here with Dr. Hirsch, who is an expert in treating patients with ADHD. And we're so grateful that you're able to come on the show.
Well, thanks for inviting me.
I think you do other things besides for that.
It's a little bit of what I do.
Okay, yeah. Could you give us an overview of, like, what does your week or day look like?
So I work at the Child Study Center at NYU. I actually co-founded that program 25 years ago.
Wow.
Just to give you a sense, this is part of an academic medical center. We are a department of child and adolescent psychiatry. And so we have a lot of research, we do a lot of teaching, and then we, of course, provide clinical care. So my role is to really run a practice of currently about 120 clinicians, 75 of which are faculty, and then there's about 40 plus trainees.
That's humongous.
Yeah.
This is pretty big.
Well, yeah, Child Study Center is big stuff.
We have 3 locations. So our main location is in Manhattan, and then we have one in New Jersey and actually one North Shore of Long Island.
Wow. Okay, cool. Here, come a little closer to the mic, I think.
Yeah.
Yeah.
Okay.
Like you're supposed to eat it.
Is this okay.
Yeah.
What flavor is it?
Okay, so at the Child Study Center, what is your main focus? Like, what diagnoses are you seeing?
So we see a wide variety because we are what would be called a tertiary care center, right? You're coming into a hospital-based program, and so we see folks who are fairly ill in a variety of ways, but we run the gamut from early childhood all the way through young adulthood. So we see preschoolers who are having difficulties with sleeping, oppositional temper tantrums and the like, in which overwhelming parents, to kids who are on the autism spectrum, or parents are wondering about that, and so we do evaluations and treatment of that, to ADHD, anxiety, depression, Tourette's, eating disorders, learning issues. I'm sure I'm forgetting a couple of areas there.
Okay.
So what we have is each specialty has a team lead, a clinical director, but they all work together as one group.
Okay.
How did you get to getting this role? Like, what was your trajectory?
Well, I wasn't always going to be a psychiatrist, if that's what you're asking.
Wow.
What was the original plan?
My original plan, look, I went to college, and it was a decision whether I was going to retire after college or I would continue to work. In college, I was really interested in chemistry. I was going to be a chemist. And I spent a year during college developing organic molecules. And it was the most boring thing I could ever do. And so I decided to go to medical school. Went to medical school. I was going to be a surgeon. And surgery sounds very exciting. You take out parts, you put parts back in. But I was a tinkerer all my life. And so I did that before medical school. The only difference was it was a body as opposed to something else.
Right.
And I said, I need something more out of being a doctor, physician. I really wanted to talk to patients. I wanted to understand them. And that's how I got into psychiatry.
That's pretty cool.
And then, so then you specialize in children.
Right.
Okay.
So you go to medical school and then you do a residency. And so in the field of psychiatry, it's a residency in adult psychiatry. And then you do a residency or fellowship, it's called, in child psychiatry. So I actually treat children, adolescents, and adults.
Okay, all of them.
All of them. Percentage of my patients are kids I saw 20 years ago, and unfortunately I haven't cured them. We can talk about cures in medicine, and so they're still with me. And I see a number of folks who I've seen for 20, 30 years.
Okay, that's cool. So when I was like researching you a bit, I saw you have a lot of
Googled
research.
me, huh?
Yeah, I Googled you. I did. I saw you have a lot of research on ADHD, so I'd love if that's okay to talk about that more, because that seems
She
like
also
your
might live with
expertise.
someone who has.
Oh, okay.
So
So she needs to really
she
understand
may need
that.
to know, you know.
Okay.
No, it's a big, I don't know, you tell me if you agree, it's like a hot topic.
Well, it's a hot topic. It's a controversial topic,
Right.
especially the treatment of it. ADHD for many people is seen as, this is our society, right? We're a rapid-paced society. We've got lots of gadgets. We've got lots of video. We have lots of things that pull our attention span, and that's why we have ADHD. But in fact, ADHD has been around for, at least in the medical literature, since the 1700s. And so there are medical reports of kids. They didn't call it ADHD back then. We'll come back to what they called it. But back then they called it, just kids with behavioral problems, impulsive, kids who made poor decisions, and the like. And then in the early 1900s, we begin to see much more in the literature of more specific symptoms, to the point where it gets called, in 1902 or so, a defect of moral control.
Oh, really?
Oh, that's interesting.
Because, again, if you're impulsive, you act without thinking. So you do things that are dangerous. You do things that turn out to be an error, sometimes illegal, without realizing it. Then it moved on to, and you'll see this in the literature, minimal brain dysfunction or minimal brain disorder, and then hyperkinetic disorder, because that tends to be what you see kind of when you're observing and what teachers see the most, right? Kids who are hyper, swinging from the chandeliers, if you will. And then we move on to a better understanding that this is more than just impulsive and hyperactive behaviors, but also attentional behaviors. And so then we have this whole ADHD, attention deficit hyperactivity disorder. So that's really where we end up today with that. When we look at, you asked the question, this controversial kind of stuff. It turns out if we do surveys throughout the world and use the same criteria, we get the same percentage of kids with ADHD in almost every country studied, about 5%.
Oh, wow.
So
that's okay.
I think
that's really good to know. The people who are saying we're overdiagnosing and not every kid that we think has it actually has it. I mean, I think that's true also.
Yeah,
but
there are certainly areas where there are pockets where it's overdiagnosed and pockets where it's underdiagnosed. I think in Thailand, they claim there's no ADHD. But everywhere else in the world, including China and Russia and the like, we see the same percent.
Okay.
Is it hereditary?
That's another big question, and really an important one, because everything has a heredity component, and everything has an environmental component. When you think about all of medicine, right, you think about high blood pressure, right? You may be genetically susceptible to it, but if you cut out salt, your blood pressure is not there, is within the normal range. But if you add salt to your diet, then your blood pressure will start to go higher. Same with asthma. Some people have more propensity to asthma. Some people have greater propensity genetically to allergies. All of these disorders have a genetic component and an environmental component. Sometimes we know the environmental component, sometimes we don't.
Right. Nature versus nurture. But it's always both.
Right.
So what are the symptoms for someone who...
Right. Like, let's define.
Yeah,
let's
define it,
right.
right?
Like, what are we talking about ADHD?
Okay.
Like,
So-
my kid has ADHD. What,
Right. So
what
there
does
are
that mean?
two core groupings. One of them is the attentional component, and the other is the hyperactive impulsive component. Let's be clear. We're not talking about someone who is occasionally impulsive or occasionally distractible. We're talking about a certain level of frequency. Now, we have to, at some point, make an arbitrary decision. Where do we draw the line, right? We can say about some illnesses, you have it or you don't. You have COVID, you don't have COVID, right?
Well, that's...
Well, at least the blood test or the nasal swab tells you you have COVID. That brings somebody else in for that discussion. But many disorders, like blood pressure, like cholesterol, have a spectrum. At some point, we say this disorder or this problem has reached the level of disorder because it will cause problems in the future, or it is causing dysfunction now. So we take a look at attention. These are kids who are distractible. These are kids who have trouble sustaining attention. These are kids who tend to lose things, tend to have a hard time putting effort into those things that require mental brain power. So that's the attentional component. Actually 9 different symptoms of attention that we look at. And we ask parents and teachers and kids who are old enough to rate. And then there's the hyperactive impulsive component. These are kids who act without thinking, right? They're the kids who run instead of walking. They're the kids who forget to look both ways. These are kids who get into frequent accidents because they tend not to be aware of their body. These are the kids who fidget, who are moving around in their chair all the time. These are the kids, when they're younger, they can't sit at circle time in preschool. In the classroom, they start to wander the class. So these are the kind of things we look at.
Right. And
Now,
in
of course, in preschoolers, we don't really tend to think about attention.
Right.
So what we see is the hyperactive.
Right. And in adults, this would be the same.
In adults, what we tend to see is the hyperactivity becomes an inner sense of restlessness. It's not so overt for many, but we see more of the distractibility. The hyperactive, impulsive stuff tends to die down a little bit, and the inattention stuff, I can't. My office is a mess. I can't stay focused on one project. I'm moving from project to project. I sit down and do something. Let me get a cup of coffee. Let me make a phone call. Oh, let me get back to this. Oh, it's time for a lunch break. Let me go outside. That's the, inattention kind of stuff. What we know is that, look, when I started out in training, we used to believe that preschoolers didn't have ADHD.
Right. So that's what I was about to ask. So how much of that is developmentally appropriate? And when would you know that it's not?
So, of course, many preschoolers aren't expected to sit and stay focused. What we're looking for is the kid who sticks out.
Right.
The kid, many years ago, the National Institute of Mental Health said we need to examine preschoolers and look at whether they've got ADHD. So they had a high threshold before they would even consider medicine for these kids. And when we looked at a lot of the kids who came to us for those studies, these were kids who were thrown out of, one preschool after another. These were parents who were completely frazzled because the kids wouldn't stop moving, and they're the kids who wear a dog leash, if you will, because parents are worried they're going to run out into the street. So they stick out. They're not the typical. And that's really, by the way, where teachers help us. Because if I'm a parent of one kid and he's maybe hyperactive, I say, well, I'm just not a skilled parent. Or I can say, boys will be boys. It tends to be seen more in boys than others. We can talk about that. It's a separate discussion. But teachers and skilled teachers, they see every year 10 to 20 to 30 kids. They can tell us that kid's not sitting He should be sitting. At age 6, he should be able to sit, raise his hands, play, red light, green light, Simon Says. And this kid isn't. This kid can't sit. And this kid is pushing in line. And this kid is running when I'm saying, let's stop. So teachers are a very important source of information for us.
Okay, great. Okay, so let's, can we talk about how you make that diagnosis?
Sure. So while ADHD tends to be what we might call the bread and butter for child psychiatrists in the same way strep throat is for pediatricians, and it seems simple to diagnose often, we spend a lot of time looking at it and trying to understand it. So typically, I'll give you what will happen with me. Patient calls my office. We will ask them to have a whole bunch of paperwork filled out. We want a little bit about the child's developmental history, at what ages they walked, talked, things like that. We want to get a sense of whether they've had any evaluations because of special ed and the like. We will meet with the parents, get a very clear history that includes not only questions about ADHD, but lots of other questions. Because attention isn't just something that's a problem in ADHD. Think about it. If you're worried about something, if you're really anxious and nervous, you're not able to concentrate on what's going on around you. So that's another area where you won't see attention. If you have a learning issue, right, and you're sitting in a classroom and that Gemara is actually Greek to you because of it, then you won't pay attention. If you're depressed, you have no interest in what's going on around you. So all of these are places where attention may play a role. And so we want to rule out all of those other things.
Yeah.
So we ask lots of questions of parents. And then what we do is we ask parents to get us information from the teachers. Either we talk to the teachers or we ask the teachers to fill out some questionnaires for us. Then we meet the child. And part of our goal with a child is some children are very good. They say, I have the wigglies. I can't pay attention at all. Some kids are oblivious to all of that. But what we want to get a sense of, are they anxious? Are they worriers? Are they nervous? Are they fearful? Are they depressed? Preschoolers and school-age kids can be depressed. Do they have oddities of behavior that would suggest a child who might be on the autism spectrum? So all that information then comes together for us to say yes or no, or maybe we need a bit more information.
Right.
That's cool. Do you do any computerized attention tests?
Okay. So one of the beautiful things we have is computers in our lives, and we use computers for everything under the sun. So one of the attention tasks of computers is sometimes been called the go, no-go task, or other terms for it, in which essentially you sit at a computer and you've got to press the space bar if an A comes up after the X. So if you're impulsive, you're going to press more frequently and you're going to have what we call errors of commission, showing that you're impulsive. If you miss it often, that suggests that you're inattentive.
Right.
But you know something? That's on the computer. I don't really care what this kid is like on the computer. I want to know what he's like in real life, right? Because the computer tells me this much,
right?
And parents, teachers, and others tell me this much.
So let's assume.
I just always thought that was so I used to do evaluations in graduate school, and we used the TOVA, that computer, and I always thought it was so interesting because it was objective.
Right.
So like to use along with the interviews and the questionnaires, it just seemed really cool to be able to show to a parent, like, oh, look, your kid
so it's
has
nice,
4, and that's like way over the normal limit. So it was just, I don't know.
Exactly. And look, the field of mental health does not have any definitive blood tests, brain scans, and the like. People aren't lining up to get brain biopsies from me. So, and the brain is too complicated, right? Other organs of the body are very simple. The heart is a pump. Let's be clear. There are pumps in your washing machine. The heart has a vital component to your life, but it does one thing. But the brain, of course, does so many different things, and it's very complex. And so parents say, well, how do you really know? And so, yes, we can do something like the TOVA or what's called the CPT or other tests and say, you see. But sometimes that test says yes and everything else about it says no. And sometimes that test says no and everything else says yes. Because, especially nowadays, kids love computers. So this kind of test isn't long enough necessarily to get them to be bored enough, if you will, to
Do you
start
think
to
there
make
might be a
errors.
value to having ADHD?
So this is the question that comes up. We've had ADHD throughout the generations, throughout the centuries. Is there something valuable that keeps it going in the genetic pool?
Okay.
Right. That's part of the.
That's another way of asking it.
And perhaps one of the things that ADHD confers for some people is greater creativity. Perhaps. And certainly there are some kids who have milder versions of ADHD who do very well overall and can take a leadership role. They may need an executive secretary or 16 executive secretaries to take care of them, or really a good spouse to help out. But otherwise, they can be very successful. We have compulsory education. We expect kids to sit a certain way and learn a certain way. And it may be that a subgroup of kids with ADHD, if they were just sent out to work in the field, would not show the same level of symptoms as they do in the classroom.
Right. I know. So is it right what we're doing?
Well, that's a whole nother story.
Right. Like our expectations of kids realistic expectations? I mean, we're not changing the system. But.
We're not changing the system. In the same way, 50 years ago, parents were told, your kid has really bad asthma. You should move to Utah. Now, that's not realistic either. Right? So, yes, we can maybe the way we do compulsory education is not the best way. Maybe for kids, certainly for kids with ADHD, sometimes a smaller classroom works better. Sometimes, and again, because kids with ADHD, about 20% to 30% have a learning issue. We want to make sure we know that, and they may need some special ed help. But we're not getting rid of compulsory education. That's what we need here.
Right.
I'm going to bring it up because Yaakov hates when I do. But Steve Jobs, we read a book, and since then, I bring him up on almost every episode.
Yeah, because he's got every diagnosis.
Because he has every diagnosis, and he was wild. Your iPhone, you wouldn't have this without him.
Yeah.
Imagine he was diagnosed.
Right.
There'd be no Apple, no Pixar.
So why do you think that though?
There would be no Woody.
Why not?
Right. So
just because he was labeled with it means that he wouldn't be productive.
I'm saying is that
that's the question. Was he actually diagnosed with it? Now here's the issue, right? We've got lots of folks who are successful in life, and lots of folks who are not so successful. Some of them are not successful because they may have something like ADHD, but some are not successful, right? And some people are very successful whether they have an illness or not. In the same way, there are people who become very successful in life even though they've had an early childhood that's been quite traumatic. That doesn't mean we should say, well, trauma is good for everybody, or ADHD is good for everybody, because some people with ADHD are successful.
Right. Fair. Yeah. Okay.
Okay, great. So now we spoke about diagnosis. Now let's talk about treatment.
Okay. So we thought the diagnosis was controversial. Treatment's controversial, right? We give something called stimulants, what the FDA has labeled a controlled substance. Most popular medicines are Ritalin or Adderall. What does it do? It essentially decreases impulsivity and improves attention. It does it by some very specific mechanisms on the two neurotransmitters called dopamine and norepinephrine. But people kind of feel like that's icky. We're giving kids medicine for something. The truth is it works very well, and it's very safe. What people don't realize is that, medicine has not been around for quite a long time in general. But there's only 4 medicines that predate stimulants. codeine,
Alcohol?
aspirin.
No.
I'm not sure we can call alcohol an aspirin, a medicine. So we have codeine, we've got aspirin. In 1922, insulin comes to market. In 1937 is the first scientific paper on a medicine called Benzedrine, which is essentially a form of Dexedrine or Adderall. Published, talking about kids, and I invite anybody to read it because it's wonderful. Nowadays you look at the scientific literature, and it's all about graphs and it's all about statistics. But back then, when they wrote stories, and so they wrote a story about a bunch of kids who were in a special school for kids who had all kinds of disruptive behaviors, and the dramatic improvement that they had with it. The problem is that amphetamines in the wrong hands can be addictive. It's not dramatically addictive for most people, but it can be addictive. And so that's why we have it as a controlled substance. I need to write out a prescription every month. I know exactly how much you're taking. I know what it's doing, what it's not doing, because I get feedback from your parents and from you, if you're old enough, and from your teachers to see, did I move the needle? When the teachers fill out a form, I have a baseline. Oh, very impulsive, very inattentive. Now I take a look 3 weeks later and say, okay, do we help?
Okay, besides for medication, what else do you tell parents to look into?
So there are core symptoms that we're talking about: impulsivity, distractibility, hyperactivity.
But can I just interject for a second?
You can, of course.
Yeah, because I have ADHD. No. But
I wondered about that. Go ahead.
Okay, so taking this drug or medicine, does that assume that it's a biological thing, right? Because if, let's say, I'm in an environment where, or something else is triggering that ADHD component or a compulsive component, then you're not really fixing the problem.
We're not fixing anything.
Okay.
We are treating something, like in most of medicine. So there are very few things in medicine that we cure, right? With the right antibiotic, we can cure an infection. We can set a broken leg, but we don't cure heart disease. We don't cure high blood pressure. We treat it. We don't have a lot of treatments that actually cure the situation. So what we're really doing is getting the symptoms under control.
Mm-hmm.
But it is biological.
Right. So there's certainly a biological component and environmental component. In the same way, migraine headaches. Let's take that, right? You get a migraine headache. You come to my office. And you say, I had these symptoms. And I say, do you have a migraine headache now? And you say, no. I say, well, does that mean it's not biological? You have asthma. You're wheezing in a certain situation because of pollen. That's environmental, but it's also biological, right? Because it's now triggered a whole biological cascade in your body. And we're going to treat that. Mm-hmm. We can treat it in two ways. We can put you in a place where there's no trees ever again, or we can give you medicine that's going to reduce some of that wheezing.
Yeah. Okay. So not necessarily curing, it's just getting the symptoms under control. Right. Got it.
I like to think of these medicines. If you ever go to a bowling alley and you...
Oh, those are the things on the side.
Exactly.
Oh, I'm that guy with it's his turn. He puts it on and it bounces
bumpers,
over.
the bumpers.
Right, bumpers, exactly, right? For those of us
guy.
who don't want to get too frustrated by throwing the ball and getting into the gutter.
Got it.
Right? So these bumpers kind of keep kids a little bit more
fair.
in the safe and narrow. Parents do that as well, right? That's part of parents' role, is to keep kids, give kids plenty of space, but not get in the gutter.
Got it. Okay.
We'll be right back this episode of That's an Issue. But first, if you're thinking to yourself as you're listening or watching this episode, wait a second, my child struggles with ADHD. My kid has anxiety or something of that sort. And you guys are on Medicaid. Your child is on Medicaid. We have a solution for you. Right Futures. Bright Futures, here we go. There's an amazing new Medicaid program that can help you get services like after-school programs, respite help, parent support, and more. Bright Futures is located in the 5 towns and services 5 towns, which is Long Island, Queens, Brooklyn, Flatbush, and more. Their team will help you every step of the way, so reach out to info@brightfuturesny.com or text or call 347-970-9531. You can find out more information at brightfuturesny.com. That's brightfuturesny.com. That's brightfuturesny.com. Pretty sure I spelled it right. And there's a solution for you. They'll take care of you, and if you're under Medicaid, it's easy as apple pie. It's a phrase that I've never used in my life, easy as apple pie, but it's true. It's great. We met with them. They're great people doing great things, and they could really help you and your children. So go ahead and check them out. Now, back to our conversation on That's an Issue.
So I was asking, okay, so maybe I could jump it off of your question. So if the medications to address the biological piece that's off in some way, then what could we do about the environmental piece? Like, let's say the kid's acting out much more at home versus in school, so then something's going on in the home that maybe can be
So there are
changed.
2 components we're talking about. One is the core impulsivity. We can change that, but we can change the behavior that leads to. I'm not doing that, Mom. You got to make me. No, I'm not getting out of bed. All of those kind of behaviors. And so the second component that we want to put in place is really to help shape the environment. And that's what we call essentially parent management, right? All of us, that would be unfair. I, as a parent, would like to believe I am a superb parent. And yet I make mistakes every single day, right? I say the wrong thing. I say it at the wrong time. When my kids were younger, my girls were teenagers, I would get this kind of classic eye roll because I said the wrong thing or did the wrong thing. We all do that. And kids who don't have a psychiatric issue, they go with the flow. So yeah, it's a bad day, we have a fight, things normalize, if you will. But kids with ADHD, their bad days continue to happen. And what ends up happening, of course, is we all like attention. As a child, as an adult, we get it one way or the other. We either get good attention or bad attention because the kiss of death is no attention. Right? And so I'm going to get bad attention. We want to teach parents that this kid needs some special kind of care, the same way if your child had diabetes and needed a special kind of recipes for his food. It's not that you're a bad parent, you just don't know how to treat this particular parenting of this child. And so we teach parents how to really parent differently for these kids.
Could you tell us more about that?
What would that look like? Yeah.
So I think, there are a couple of things. One is, the first step is that kids like this tend to try our patience over and over again. We may love our children, but sometimes we don't like them. And so what we want to be able to do is get to like them again, which means spending some time in which the child says, Mommy, Daddy, will you play with me? And let the child decide what they play. So that means they get special time, whether it's 5 minutes, 10 minutes, 15 minutes, a night. Then what we want to do is reward children for good behavior, right? People say, "Oh, I'm bribing my kids. It's not a terrible thing. I don't want to give my kid, candy or this or that." And I turned and I said, you go to work and your boss says to you, "I like what you're doing. Keep it up. It's really great. Oh, we're not paying you this week." How long are you going to last at that job? All right, we expect kids to do things, and many kids are very good about getting, feeling good about the tap on their back, saying, "Hey, good job." But kids with ADHD, they need something more. They need something tangible.
Why? Why are you saying that?
Because the way their reward system works a little bit differently. They don't have the same feeling of success by just simply saying, "Chaim, you did a good job."
Why?
That's the brain differences, okay? So kids with ADHD have different brains.
Wait, do we see that on brain
We do.
scans?
We do. Actually, it looks like that kids with ADHD and adults with ADHD, their brains are slightly different. There are two kinds of brain scans we look at. One of them are called MRIs, which simply look at the structure of the brain. And what we see in kids, if we look at them sequentially, is that kids' development of their brain is delayed by about 3 years. So in some ways, they're 3 years behind.
The whole brain or just the prefrontal cortex?
The prefrontal cortex.
Okay, that's like
That-
right
yeah,
here.
The front of the brain, the
knew that.
thinking part, the executive part of the brain. The second is that these their brains tend to be a little bit smaller in certain areas. The third is that when we look at how they function around rewards, they are slow to feel good about just verbal rewards compared to tangible rewards.
Interesting.
That's cool. Do we see that on a scan? Like
So-
on a...
So you can do these kind of very fancy tests where you put a kid in a scanner and do some reward kind of tasks.
And then you
And
see
they
like
have-
the parts light
Yeah,
up.
Exactly.
That's
Now,
very cool.
so families going to say, well, put my kid in the scanner, right? And then you'll have the diagnosis. You'll tell me what is,
Try giving a kid a reward when there's like machine.
and so to be clear, if we took 1,000 kids with ADHD and 1,000 kids without ADHD, we would see differences, but we'd also see lots of overlap. In the same way, if you took two classes and they both took the same exam, in one class the average was 80, the other class was 85, and I said I have a kid with 83, you wouldn't know which class they came from.
Right.
Right. Okay. No, but that's really cool. Okay, so we were talking about just going back to you were saying about parents giving tangible rewards.
Right. Okay. So because you're saying their brain
Is wired differently.
wired differently. Interesting.
Okay. Also, just to, I think it's somewhat similar to bring up like the timing piece. Like for a kid with ADHD, if you say like if I'll give it to you next week,
Right.
that's not like they can't handle
Immediacy.
that. Right.
Immediacy, right? So what we tend to do is we tend to develop two levels of rewards. One is, you get a sticker, but then you get 3 stickers and you turn in for something more tangible. The other piece of this, of course, is the parents say, I tried it, it didn't work. He wasn't interested in the reward. We need to make the rewards work by making sure they can get the reward. If we make the bar too high, they don't get the reward, they're going to stop immediately. So we want to make it easy, right? If we said to you, again, you're not going to get paid for the first 6 months until we see whether you do a good enough job. You're going to be looking for another job right away, right? And so we want to say, Chaim, if you get up within 15 minutes of the time I wake you, 2 days out of the next 5, you get a reward. Because if I say 4 days and 1 day goes by where he doesn't get it, then right away, that's the end of it, right? I've lost. He says, why should I try the next 3 days? I'm not getting a reward anyway. So we always want to build rewards that you can gain. That's the goal of it. And then over time, you make it a little bit more difficult. Right. You expand it. You also don't want to decide, you don't do this, you don't do this, you don't do this, you don't do this. So let's make this list of 12 different things. Choose one thing at a time.
So like in adults, because let's say you were discussing a lot about children. In adults, what are the symptoms that you see that, someone who, I don't know, young adult or even, middle age, what type of symptoms are they dealing with that you...
So mostly they're dealing with attentional issues. They can't focus. They have little patience. They're trying to do their work and they find that their mind wanders. They have little patience, the kind of folks that can't sit for long periods. They need to kind of get up. Longer than others, they may say, I'm sitting, my in-laws' house, my future in-laws' house, I got to be good so I can handle that. But in other situations, they can't go to a shul minyan that's more than 20 minutes long, kind of thing, because then they don't have the patience for it. They don't have they can't focus long enough. Okay. And so that's really, now what does that mean? Adults tend to get into more car accidents and more speeding tickets. Adults who tend to have they tend not to reach their abilities as much as folks without ADHD. So, because they drop out of school more. They don't finish college. They don't get to college. They have more struggles with others, right? They have a spouse and they're disorganized, and now they've got a list of things to do and they don't get to it. It's going to cause arguments. And so all of those things we begin to see.
What about like compulsiveness? Where do you see that?
Compulsiveness?
No. What did I say?
Oh, impulsiveness, you mean?
I'm sorry.
Right.
I'm going to edit that
Right.
one.
Right, that would be
Yeah.
the speeding.
So yeah.
That would be impulsive.
You know,
Impulsive, yeah, I'm sorry.
it's making decisions without thinking through the consequences, right? I just bought that new TV set, right? We have 4 TV sets at home. Where are you going to put this one? Well, but you know, that one's 3 inches, but you just had this installed last week. So these kind of, whether it's impulsive decisions, purchases, all kinds of things that folks can do that afterwards they say, I should have thought better about that.
What about not preparing for something?
Mm-hmm.
Yeah.
Right?
Right.
Let's say winging it.
Yeah.
Would that be a symptom?
So what we sometimes see is, here you have a project, okay, and you have steps to the project. And what you do is you skip the steps, right? Because you haven't prepared, you haven't thought it out. Suddenly, you're in the middle of doing something and realize, I don't have the proper equipment for it. I didn't think it through. So all of those are the kind of things we'll see with ADHD. These are folks who have no patience standing in line. They're going to go to, Gourmet Glatt, pick up a bunch of things for their spouse and for the barbecue, see this long line and say, I'm not standing in line. Just leave the cart and go, right? They have no patience for those kind of things.
Also, time management.
Right.
Time management.
Like, I'll be there in 5 minutes. It's like,
Right.
no, you're half an hour away.
Right.
You can't possibly get her in 5 minutes.
Does this affect religiosity at all? Like the intersection between the two?
Not necessarily. Again, we need to go back a little bit because we ask kids to spend a lot of time in school. And in yeshivas, we spend a lot of time in religious instruction. If I'm very bright, the first 4 years of elementary school is a breeze, right? Because the Rebbe repeats it over and over again. I don't have to listen with half an ear 50% of the time, and I'm still going to get it. But then I'm going to hit Gemara. And what's going to happen is, okay, now, this Tana says this, that. Before I turn around and say, I lost my patience, I lost attention, now I'm lost. Now I start to say, this is not worth it, right? And then I start to have more and more difficulty in a yeshiva in which half my day is that kind of
Or
stuff.
davening also could be long.
Davening is long. And so one of the things we sometimes make sure we do, for example, with kids is we give them the medicine and make sure that it starts to work even before they get to school. Right? We don't want it to start working 20 minutes or a half hour, 45 minutes into the school day because that already sets up a cycle of I haven't started to pay attention. Right? The medicine doesn't whisper in your ear, pay attention. It allows you to pay attention. So if you're not set up to pay attention, it's not going to work. And that's part of the difficulty we have if for the first time we're seeing a teenager who's already had lots of difficulty, lots of school failure. And we say, oh, we'll give you medicine, but the kid's has no interest anymore.
Right.
And so we can make their brain focus in the same way glasses help me focus, but if I'm not interested in looking at it, I'm not going to see anything.
Right. We have to intervene early if we want to, right?
Interesting. Do you have any stories or encounters that you've watched a kid or a person challenge with this and then use the tools that you've provided and they were able to overcome their circumstance?
So I think one of the beautiful things about ADHD medicine is it works right away. So you can see differences almost immediately. A colleague of mine, now almost 40 years ago, did a study in which he videotaped parents and children with ADHD. And he showed the videotape to medical students and asked, what do you see? And they say, we see lots of frazzled parents. The next week he shows the videotape again and says, looks like you gave the medicine to the parents. What you did was you treated the kid's ADHD. So all of a sudden you have better relationships between child and parent. You have a child who's much easier and ready to do schoolwork, which means success in school as opposed to failure in school. And then you have, and then that moves all the way across. So we've seen kids, of course, all ages, but we've also seen college students, we've seen law students, we've seen medical students who report dramatic changes in their ability to get things done. There are lots of boring tasks, even the most exciting work, there are lots of boring tasks. Whether it's writing notes in medicine and mental health, whether it's, taking care of your checkbook and balancing it, all of those are boring things. And for people with ADHD are the most difficult things, but in some fields will trip them up. Right. They can be very bright. They can be a great lawyer. They can be a great, doctor, but if they can't do what is required, then they're going to get into trouble. So I'm going to tell you a story.
Okay.
This goes back many decades, the last recession.
Okay.
Right? A physicist comes into my office who is doing remarkable work. And he's got 16 postdocs and interns, all kinds of folks working with him, and they're the ones who manage his lab. Recession comes, cutbacks, dollars are lost. He loses all of his postdocs except for one or two. And he's lost. He can't do it anymore. Suddenly he has essentially farmed out his executive decision-making and all his, to his postdocs, and now he's unable to do it. He can't concentrate, can't focus. And you go back in time, you speak to his spouse, you speak to his parents, and they say, he's always been a space cadet. But he was brilliant. But now he needs medicine.
What age was that?
40.
Wow. I mean, for 40 years, his environment was set up that it allowed him to function.
Exactly. So that's the beauty of, and the complicating piece here, right, is that if you set up your environment right, you can get by. Now, sometimes Steve Jobs, I hear he was a terrible boss.
Yeah, that's
right. And so he managed to do some wonderful things, but he probably had very little patience, right? He was a perfectionist, also very little patience. And what we see is sometimes people who are impulsive also have problems with their emotions, and they get angry more easily, and they get more irritated more easily, and that's the downside as well.
But that's something that can also be worked on more from a therapy, like behavioral approach versus medication.
Right.
Like the medication's not really going to do anything with that.
Helps.
Like a stimulant would do?
Well, so it's interesting. We see kids, a subgroup of kids with severe aggression. They get really angry fast. They get physical. A colleague of mine did a study out at Stony Brook. Kids with such severe aggression, they ended up in the hospital. So they have physical aggression. They're breaking windows. They're kicking, they're screaming, they're biting. These are kids 8, 9, 10, 11, 12. They all had ADHD. He optimizes the medicine, and 50% of them lose their aggressive symptoms. Right? In order to be able to utilize therapy, I need to be able to think.
Right.
We aren't going to be able to get the idea of if you count to 10 before you lose it, and you won't lose it. It's a joke, right? That really doesn't happen, because at some point you lose it, and there's no going back. One of the most famous studies in ADHD was called the MTA study, the Multimodal Treatment Study of ADHD. It was developed in the late 70s, early 80s, looking at kids with ADHD and treating them with medicine and behavioral therapy, with just behavior therapy, and then a subgroup was sent out in the community. And they've been monitoring them now for almost 25 years or so. But what's interesting is the study was developed at the request of the National Institute of Mental Health, and they were most of the researchers were psychologists who were hoping to find the magic formula for therapy. And we didn't. It turned out the therapy was nice. Parents loved the therapy, which was the kitchen sink of therapy. It was the gold Cadillac. It was the Lamborghini of therapy, I'll tell you if you want. And it didn't do a whole lot better than medicine. The combination of therapy and medicine didn't do better than medicine.
Medicine alone. Oh, wow.
It helped for the subgroup of kids with anxiety.
But the medicine doesn't give you the skills that you
That's
need.
right.
So how
That's
could
right.
you not need both?
Medicine doesn't
She's
give you the
CBT,
skills.
so-
Right.
Yeah, no. So yes. So this.
You're in
so,
the wrong field then.
So that's where
No, that's
parent
why I'm, like,
that's where
surprised
parent
by this.
management helps some of that. And yes, we can provide kids with other skills, but without the medicine, those skills go out the window.
Right. No, so
So-
that's why I would think you need the medicine, but you also need the
Right.
skills.
So it's
Because if
interesting-
the kid's on the medicine, but they still, let's say, don't have social skills,
Right.
they're not going to have friends, even
There's
just
a
because they're not
subgroup of
impulsive.
kids, medicine alone does the trick. And some group
Right.
of kids who need parenting,
Right.
maybe individual CBT, maybe in young adults who have CBT. The number of wonderful research that's being done out there, including things like mindfulness for adults with CBT, group work, organizational skills work with adults and kids with ADHD. And that can be helpful, absolutely. For those kids, again, what's interesting about therapy is like any other therapy. Most of medicine has therapy too, right? It's just a different kind of therapy. You go to your doctor and he says, your blood pressure is a little bit high. He recommends environmental change. That's therapy.
Right.
For him,
Exercise and
Exactly.
right.
Exactly, right? But then you have to do the work, right? I can't force it on you. Parents sometimes think, well, I'm bringing my kid to you and you're going to fix them. And that's why parent work is so important in this, because that 1 or 2 hours a week that I might see the child in my office isn't going to go a long way unless I have the parents involved as well. And I can get the kid to buy into it.
Right. I liked how you framed it before, that it's not that they're bad parents, it's that they need a specific type of parenting for this kind of kid. It doesn't say anything about them as people Yeah, I think that was a good way of putting it. You mentioned just organization. I wanted to talk about that. Do you have any tips, or what would you suggest in terms of increasing organizational skills for kids with ADHD?
So we know that about 50% of kids with ADHD have organizational skills deficits. It's a wonderful book, not written by me, so I'm not here to promote anything I've done, but Howard Albacoff, Richard Gallagher, and Alana Spira, who worked two of them continue to work with me. Howard Albacoff is one of the major researchers, wrote a book for clinicians and a book for parents on organizational skill training. And we actually do it in our program, where we essentially work on things like time management, right? So kids don't, they think it's, this is going to take me either 30 seconds or this schoolwork is going to take me a half hour. And so we actually use a timer to teach them how long things take. We help them with their backpacks, so we have them come in and we kind of clean out we have them label things. And we kind of work with them to really develop these kind of skills and these habits.
I work in a school, so I do a ton of this. So, yeah.
What school
it's
do
great.
you work in?
After high school.
Oh, very nice.
So I'm doing this with high school kids, but if they got it in second, third grade, that would be even better. I started at a younger age.
Probably every kid should have some kids will be super fantastic and probably can teach it, but a lot of kids really would benefit in the same way they benefit from study skills. Right. And we don't necessarily do that, in the classroom.
Right. So a kid, let's say, who has some ADHD symptoms, right? So let's say they're disorganized, they're hyperactive, but they generally function. The parents aren't frazzled, all of that type of stuff. So we wouldn't diagnose them, right? But they could still benefit from
So we might
some help.
diagnose them with there are terms within our diagnostic manuals that allow for a partial diagnosis. But you're right. not everybody needs the kitchen sink of treatment. A kid like that might just need some sessions of CBT, some small parenting work, making sure there aren't any learning issues that may be impacting, and then they're good to go. They may come back at a future time and may need medicine. In the same way, there are some kids who need medicine in elementary and junior high school, and then in high school they seem to outgrow it enough that they don't need medicine.
Oh, that's cool.
Yeah.
That's very
Again,
interesting.
what we need to build is success. What do we ask kids to do, right? We send them 8 hours to 10 hours a day to a school and say, this is your job. So imagine, I sometimes use this analogy, my boss comes to me and says to me, Glenn, I'm glad to see you at work today. Just want to let you know you're doing a lousy job. Right? So think about the kid who's unsuccessful, who gets his grade back and it's a C- with a half smiley face and saying, you could do better if you tried, kind of thing. Yeah, how you feel about that, right? That you feel awful. And then if you really don't do well with friends, that's the other kiss of death, right? You know, if you don't have friends, if you don't do well academically, then you're checked out. Then these are the kids who we worry about the most. And so anything we can do, going back to the analogy of bumpers, right? Anything we can do to keep them on that straight and narrow, breed academic success, develop, classrooms that cater to kids with more learning issues, provide those rewards in school with kind of a daily report card that gives them a sticker for good performance. Provide them with a tutor that pre-teaches them if necessary. Help them with social skills if they're having. Find the right kind of, not every boy is interested in basketball. Let's find, what they're interested in and see whether we can connect them. These are the kind of things we can do to kind of help success.
Don't say girls. I know we didn't speak. We speak about boys a lot, but what about girls? Or is that a
so we know is when we look at the studies, the epidemiological studies, the kind of surveys in countries, girls are identified less than boys. Probably boys to girls is 2 to 3 to 1. Part of the reason for that is boys are bred to be rough and tumble, right? Boys tend to be much more energetic. And again, remember where we tend to pick up these kids in the classroom. So if I'm a kid sitting in the back of the room, just distracted, inattentive, not disrupting the class, I will be less likely to be picked up by the teacher as having a problem. If I'm calling out, that teacher's calling someone in the therapy department to say, help us right now. Something going on here. And girls, when they're hyper, they tend to be chatterbox, right? They talk a little bit too much. That's what we tend to see as opposed to, running up and down the hallways.
Okay, so it just manifests a little bit differently.
Right.
But so are the actual numbers probably equal?
I don't know that we know that for sure. I think probably boys are the weaker sex.
Wait, just with this.
We see more autism in boys. We see more ADHD. We see more oppositional. We see more conduct disorders in boys. When it comes to girls, we see more internalizing problems like anxiety and stuff like that.
Right, more anxiety, more depression. Yeah. Right. Okay. We're even. Right. Okay, so the girls are the inattentive piece.
They will have some impulsivity and hyperactivity, but on a much lower level. So again, they won't necessarily be recognized for that kind of problem. And I know multiple times over the years, I'll see a kid and they're not performing academically, there are no learning issues, and I'll call the teacher and the teacher say, she seems fine. I said, is she paying attention? Now that you mention it.
Right.
So because they're not standing out. I mean, a teacher's got 30 kids in the class, 25 kids, 24, whatever number it is. So, the bright kids stand out, the troublemakers stand out.
Right. Okay, let me ask you a question about ADHD and anxiety. Mm-hmm. So using a stimulant for ADHD, could that increase anxiety? So for a kid who has both,
right. So
that could do some damage, right?
We like to try to understand ADHD as kids who don't think, right? They act without thinking. And anxiety is the opposite problem. Right. They think too much.
Right.
Right. And so what we do is with medicines like stimulants like Ritalin, we essentially want the stimulant to whisper in the ear, think tatala before you do something, right? Think before you act. If I also have anxiety, there's the potential for that anxiety for me to worry more as well.
Yeah, he's got two angels on his
Right. Well, it turns out that a lot of kids with anxiety, with ADHD, their anxiety has to do with their academic and social performance.
You're saying it'll fix.
So actually we see an improvement in a large number of kids with ADHD and anxiety just with the stimulant. The kind of anxiety that tends to not go away or worsen, or rigidity and obsessional kind of anxiety.
Right. So like ADHD and OCD.
Right.
So what do you do about that?
Then I put on my witch doctor hat and mix lots of different chemicals up.
Well, there's non-stimulants, right? That can be given?
Yes, I'm sorry. There are non-stimulants, exactly. So there are medicines. So the
You're really Dr. Snape.
Yeah.
Professor Snape.
About 70 to 75% of kids do very well on stimulants. About 25-30% don't, for a variety of reasons, whether it's side effects or any number of reasons, including worsening of some symptoms like tics or anxiety. In that case, there's a group of medicines that are called non-stimulants, for, we can call it very fancy technical words, that work with a slightly different mechanism and don't exacerbate anxiety.
Okay.
But they don't work as well. So for some kids, it works just fine. But some kids, they don't work as well.
Okay. But there's options. Okay. You have any more questions?
Oh, this has been amazing.
Yeah. No, thank you so much. We appreciate your time and coming out and your expertise.
Yeah, it's really informative. And
well, thank you so
much.
Our
listeners are really
I enjoy this.
Yeah.
Thank you so much.
Thank you.
Take care.
Thank you so much for watching or listening to this week's episode. If you don't yet know, we have a free call-in hotline where you can listen to any episode of That's an Issue or any Living L'Chaim podcast. And it's great for people that don't use the internet or don't have easy access to Wi-Fi or Ethernet. So go ahead and look at our show notes for the number. We have an American number, a UK number, and an Israeli number. And also, if you are thinking, hey, I need some more help, our friends at Relief Help are there to help you and find the right person to walk you through whatever challenges you have along the way. So you go to reliefhelp.org, give them a call at 718-431-9501, or you can send them an email at info@reliefhelp.org. Please subscribe to our podcast if you haven't yet. We have some incredible guests coming up on That's an Issue. Until next time, be safe. Living L'Chaim.